Chapter 16 of our behavioral neuroscience textbook talked about psychopathology. So segment 2 started off on page 508 and first started talking about antipsychotic medications that revolutionized the treatment of schizophrenia. So in the 1930s, there was no effective treatment for schizophrenia. So researchers turned to lobotomies, which are surgical separations of a portion of the frontal lobes from the rest of the brain. And these were performed on about 40,000 people in the United States alone. And another method that developed during this time period was psychosurgeries, which were surgical modifications of the brain to treat psychiatric disorders, smaller lesions, and they were rarely performed. But by 1954, chlorpromazine, or also known as thorazine, was developed, and this antipsychotic drug belonged to the class of phenothiazines, and it was originally used as an anesthetic, but it soon replaced lobotomies as a treatment for schizophrenia. And the drug was effective at reducing the positive symptoms of schizophrenia particularly. And so eventually antipsychotics were developed, or also known as neuroleptics, and these are a class of drugs that alleviate schizophrenic symptoms, and they were eventually found to do so by blocking postsynaptic dopamine receptors, or D2, specifically D2 receptors, just as chlorpromazine did. And so it was from this development that the dopamine hypothesis was created, and this hypothesis says that people with schizophrenia suffer from an excess of either dopamine release or dopamine receptors. Either way, they have too much dopamine. And other evidence that has come to light that supports the dopamine hypothesis is drug abuse. So amphetamine abusers who developed a drug tolerance when taking large doses, up to 3,000 milligrams a day, they developed paranoia, auditory hallucinations, and suspiciousness and weird motor behavior. And these delusional and psychotic states with schizophrenic-like symptoms is called the amphetamine psychosis. And so another major class of drugs that developed in order to reduce the schizophrenic symptoms were the typical antipsychotics, the first ones. And they shared an antagonistic activity at the D2 dopamine receptors, and an effective dose can be predicted by the affinity for D2 receptors, so this also supports the dopamine hypothesis. And yet more evidence for the hypothesis is that treating patients with Parkinson's with an L-DOPA, which is what eventually is metabolized into dopamine, this can cause schizophrenic-like symptoms. But some flaws in the dopamine hypothesis is that there is no correspondence between the speed with which drugs block dopamine receptors, which is at a rapid pace, and how long it takes for the symptoms to diminish, which can sometimes be up to weeks. And also, some people with schizophrenia don't respond to dopamine antagonists. So another class of drugs developed, and that is atypical antipsychotics. And these were developed specifically to avoid the motor side effects that typical antipsychotics had. And the atypicals have actions other than the dopamine D2 receptor antagonism. I mean, they have that antagonism, so they share that with the typicals, but they have other actions because they have a high affinity for other types of receptors. So, for example, clozapine blocks serotonin receptors as well. Also, an important note to make is that clozapine can increase the dopamine release in the frontal cortex, which is actually contrary to the belief about in order to reduce schizophrenic symptoms, you have to decrease the dopamine levels. And finally, a British study suggested that typical and atypical antipsychotics were equally effective, despite beliefs that atypicals are more effective. This probably comes from the fact that they are less likely to cause motor side effects, but they also are more likely to cause weight gain than typical antipsychotics. So box 16.1 talks about the long-term effects of antipsychotic drugs. So the traditional antipsychotics can have undesirable side effects, including maladaptive motor symptoms, which is called dyskinesia, and they are often transient and disappear when the dosage is reduced, but sometimes they emerge after prolonged drug treatment and become permanent. And these motor effects are called tardive dyskinesia, which involves repetitive involuntary movements, especially in the face, mouth, and tongue. And in addition, long-term treatment with typical antipsychotics can also lead to supersensitivity psychosis, which involves a prolonged blockage of dopamine receptors and the increase in the number of dopamine receptors, which leads to supersensitivity. And in some patients, stopping or lowering the drug dosage can increase positive symptoms, contrary to the normal belief. And supersensitivity psychosis can be reversed by administering increased doses of dopamine receptor blocking agents. Another major hypothesis regarding schizophrenia is the glutamate hypothesis. So the foundation to where this hypothesis started off was the development of phenylcyclidine, or PCP, which is commonly known as angel dust. It originally developed as an anesthetic, but this psychedelic drug produces effects very similar to those of schizophrenia, it was found, both positive and negative symptoms, which led to it being classified as a psychomimetic drug, meaning that it provokes auditory hallucinations, strange depersonalization, disorientation, and potential violence. So PCP is a NMDA receptor antagonist, meaning it blocks the NMDA receptor's central calcium channel and thus inhibits glutamate from its effects. Another important drug that led to the development of the glutamate hypothesis was ketamine, which is a dissociative anesthetic drug, again, like PCP, that is also an NMDA receptor antagonist. So the findings and discovery around these two drugs and how they work led to the glutamate hypothesis, which is the theory that the underactivation of glutamate receptors, which there are 8 types of, causes schizophrenia. A final note that the text makes about schizophrenia is that there's no one single cause and that there's probably multiple factors that interact with each other, such as genes. Genes alone cannot account for schizophrenia, and that a variety of stressful events can significantly increase the risks. Stressful events include physical, emotional, and lifestyle changes, prenatal stress or birth complications, or even living in the city. So the modern view is that schizophrenia is caused by the interaction of genetic factors and stress together. A next major psychological disorder that the book talks about is bipolar disorder, and the book emphasizes its similarities with schizophrenia. So bipolar disorder was formerly called manic depressive illness, and it is a psychiatric disorder that is characterized by periods of depression that alternate with excessive, expansive moods. So some key characteristics of this disorder are mania, which is the sustained overactivity, talkativeness, strange grandiosity, increased energy, and the high, the mood that involves the brain being more active. And then a next major symptom is rapid cycling. So this happens when there are 4 or more distinct cycles in 1 year, at least. And cyclothymia involves less extreme moods, but cycling between dysthymia, which is poor mood or a mild depression, hypomania, which is a state of increased energy and positive mood, but it lacks some of the bizarre aspects of regular mania. So bipolar disorder is more similar to schizophrenia than depression because of extreme talkativeness and mania, the fact that bipolar disorder patients typically have enlarged ventricles, just like schizophrenic patients. And many of the genes that are implicated in schizophrenia are also implicated in bipolar disorder. And the main gene implicated in bipolar, though, is the gene BDNF. So as for treatments, typical antipsychotics don't seem to help, but atypical antipsychotics may help dampen the mania a little bit. But the main primary course of treatment for bipolar is lithium, which is an element that is often administered as a drug and is most often used as a treatment and blocks manic phases.